Hello students, today we are going to deal with glomerular diseases. At the outset, we should know the different components of the kidney for a better understanding of the kidney disease. These components include the glomeruli, tubules, interstitium and blood vessels. Diseases affecting each one of them may have different clinical features. Patient with glomerular affection present with hematuria, proteinuria, puffiness of face and oliguria. Mechanism of glomerular injury in these cases are immune mediated. Tubular diseases present with polyuria, nocturia and here the renal concentrating ability is deranged. These patients may initially present with acute renal failure and tubular damage may be due to toxins, infections and in some cases genetic abnormalities. Disease of the interstitium may present with acute renal failure and inability to concentrate urine, which is similar to the tubular diseases. Drugs and infections are the main culprits behind interstitial diseases. Lastly, the disease that affects blood vessels may cause ischemic damage and may bring the patient with hypertension, acute renal failure or papillary necrosis or renal infarcts. Etiology behind this vascular affection are mainly drugs and some congenital anomalies. Though diseases affecting four components may differ in their clinical presentation and therapeutic options, they are interdependent and disease affecting one may affect the other component secondarily. For example, disease of the blood vessels may invariably affect other components by means of ischemia. Disease of the glomerulus may impair the blood flow to the tubules so that there may be ischemic damage to the tubular epithelium. In this class, we are going to deal with two important glomerular diseases, rapidly progressive glomerulonephritis and proliferative glomerulonephritis. To understand the glomerular diseases, a good knowledge, histological knowledge of glomerulus is very important. Afferent arteriole divides into multiple branches which form 5 to 8 tufts. Each tuft of capillary has a central glue known as mesangial matrix, in which you may see mesangial cells which are equivalent of macrophages. Capillaries are lined by endothelium which is of fenestrated type, that is, they have holes through and through their cytoplasm. These endothelial cells sit on a basement membrane. However, portions of the endothelium adjacent to the mesangium has no basement membrane. Outside the basement membrane are the epithelial cells known as podocytes, as they may have many food processes which interdigitate with each other. In between the interdigitations, there is a gap known as filtration slit. These capillary tufts will be hanging a Bowman space. The filtrate that drips into the Bowman space, which later will be converted into urine, has to pass through this filtration a structure known as filtration bed, which is composed of endothelium, basement membrane and food processes of podocytes. If you look at this structure of filtration bed, endothelium, which is of fenestrated type, will have holes with the size of 70 to 100 nanometers, and these filtration slits of podocytes are negatively charged and with a pore size of 20 to 30 nanometers, which are represented by black arrows here. And this filtration slit also has got some proteins which dictate the property of filtration, and these proteins include nephrin molecules, actin filaments and podocin. So any alteration in the endothelium, any alteration in the basement membrane, alterations in the podocytes will result in the abnormal filtration, which may result in proteinuria and hematuria. Glomerular affection may bring the patient with the following syndromes. One is, some may come with nephritic syndrome, some may have nephrotic syndrome, and some may present with rapidly progressive glomerulonephritis, and isolated urinary abnormalities may bring the patient with hematuria and proteinuria, and lastly the chronic renal failure may be the presenting feature of a glomerular syndrome. So nephritic syndrome mainly in the form of hematuria, azotemia, mild proteinuria and hypertension. Nephrotic syndrome will have a very heavy proteinuria which is around more than 3.5 grams per day excretion of protein in urine. These patients will have hypoalbuminemia, hyperlipidemia and lipiduria. Rapidly progressive glomerulonephritis will have proteinuria, hematuria and acute renal failure. Chronic renal failure patients present with azotemia, later they will land in uremia. If you look at the glomerular injury, this glomerular injury is mainly mediated by antibodies, and these antibodies may be in situ immune complex deposition or it may be circulating immune complexes. In addition to antibody mediated injury, glomerulus may also be affected by cell mediated immune injury, and activation of complement pathways may result in injury to the glomerulus. If you look at the in situ immune complexes, these immune complexes will form as a result of abnormal proteins within the basement membrane and mesangium, or the proteins coming outside and getting implanted in the mesangium or in the basement membrane. So examples for this are the exogenous infections, hepatitis B virus, C virus, and drugs, or some of these proteins may be circulating and they get entrapped in these places. Examples for this is DNA, nuclear proteins, immunoglobulins and immune complexes. Circulating immune complexes is again one more mechanism by which they get entrapped in the glomerulus and they initiate inflammatory reaction. So these include the circulating immune complexes directed against the DNA, say for example in the case of SLE, or in the patients suffering from cancers may have tumor antigens against which antibodies are formed and they are forming complexes and circulating. And exogenous agents like infections which I enumerated already, like these hepatitis B, C, malaria and leishmania of that sort, and these complexes may get entrapped in the glomerulus. Cell mediated immune injury is also one of the mechanisms that is proposed, and activation of alternate complement pathway may initiate injury in the glomerulus. So antibody mediated mechanisms I told already, the in situ antigen reacting with antibody. This may be fixed, that is already the proteins that are already present in the collagen or mesangium may be a target for antibody production, and these antibodies come and get deposited there. Or extrinsic molecules may be planted in the glomerulus like infective agents or circulating DNA or other antibodies may get planted there, and that may initiate immune complex formation. And in some cases there may be circulating antigen antibody complexes. These may get entrapped in the glomerular filtration bed and cause an immunological injury. Circulating immune complexes has no specificity for glomerulus, but because of their physicochemical properties like their size, the charge and hemodynamic factors peculiar to the glomerulus, they get entrapped in the filtration bed. So examples for the circulating antigen and antibody complexes include endogenous antigens like DNA, nuclear proteins, immunoglobulins, microbial antigens like treponema which causes syphilis, malaria and hepatitis C virus, B virus, and in the case of some tumors like renal cell carcinoma, the patient can have circulating immune complexes. As I told already, immune complexes has no specificity for glomerulus, they just get entrapped in the glomerular filtration bed. Once they are in the filtration bed, they activate complement and recruit inflammatory cells and they cause damage. Types of localization of immune complexes may vary, and this, by identifying this pattern, it is possible to identify the pathology. So these patterns include subepithelial humps, which is represented by number 1. So that is the antigen antibody complexes sit below the epithelium or podocytes. And subepimembranous deposits, again they sit along the basement membrane, and subendothelial deposits just below the endothelium, and mesangial deposits, some of the antigen antibody complexes go to the mesangium and reside there. So what are the factors that localize the immune complex deposition in the glomerulus? There are two main factors which contribute this: the charge and size of the molecule. Subepithelial localization is facilitated by highly cationic molecules. They reside in subepithelial region. Highly anionic molecules, large molecules, they tend to be localized in the subendothelial region. And neutrally charged particles or molecules may get entrapped in the mesangium. So these antibodies to the glomerular cells and antigen antibody complexes cause damage to the mesangial cells, endothelial cells and visceral epithelial cells. So mesangial cells may result in damage to mesangial cells may result in mesangiolysis, mesangial cell proliferation, and endothelial cell damage may result in endothelial injury, and which may initiate thrombus formation. Visceral epithelial cell injury may result in heavy proteinuria. So cell-mediated immunity may play in some of the glomerular diseases. The evidence is the presence of macrophages in the glomerular in such cases, and also demonstration of T lymphocytes in the glomerular products. Epithelial injury caused by antibodies to visceral epithelial cells, and the culprits are the drugs, toxins. Experimentally, it can be induced by puromycin. Changes in epithelial cells, already I told: vacuolations, effacement of food processes, retraction of food processes, and detachment of cells from the glomerular basement membrane. So this is the normal food processes, and here on the right side you may see the effacement of food process where they lost their structure, and next to it, adjacent to that, there is what we call detachment of food process, and which alter the filtration bed. So what mediates glomerular injury once there is antigen antibody complex deposition? So this is like any other inflammation. The cells that participate in the glomerular injury are the neutrophils, monocytes, macrophages, platelets, and resident glomerular cells, that is macrophages, known as mesangial cells, and other soluble mediators, that is cytokines, soluble mediators of inflammation, that is cytokines. You can see here antigen antibody complex deposition is associated with complement activation, with further recruitment of inflammatory cells and liberation of oxidants, cytokines and chemokines, which amplifies the inflammatory reaction. And directly this antigen antibody complexes or the antigens may be cytotoxic to epithelial, endothelial, mesangial cells. So activation of platelets again results in thrombus formation. Macrophage recruitment is associated with liberation of growth factors which promote the proliferation of endothelial cells, promote proliferation of visceral podocytes. And mesangial cell proliferation is again mediated by the liberation of the various cytokines, and recruitment of T and NK cells is associated with direct damage to the altered structures. So these are mediated by soluble cell factors, which we will call as cytokines. So the glomerular diseases are mainly divided into two categories. One is primary glomerulopathies and secondary glomerulopathies. Primary glomerulopathies are those diseases wherein the glomerulus is the primary target for destruction or affection, whereas secondary glomerulopathies are those conditions wherein there is systemic infection or systemic disease process in which the glomerulus is secondarily involved. The examples for these primary glomerulopathies are acute proliferative glomerulonephritis, rapidly progressive glomerulonephritis, minimal change disease, membranous glomerulonephritis, membranoproliferative glomerulonephritis, focal segmental glomerulosclerosis, IgA nephropathy, and lastly the chronic glomerulonephritis. So, this is an important slide wherein the nephritic features are listed. The patient with nephritic presentation, glomerulonephritic presentation, usually will have hematuria and his urine will show red cell cas, and invariably they are hypertensive and there may be mild proteinuria. Initially these patients will present with periorbital edema to start with, and later they may go in for generalized edema. Their urine output will be very low, and which we will call as oliguria, and invariably biochemical alterations will occur in the form of elevated creatinine and the urea, which we will call as azotemia. Coming to the two glomerulonephritis proper, the first one acute proliferative glomerulonephritis, which was earlier called as post-streptococcal glomerulonephritis. Here there is proliferation of glomerular cells, neutrophilic infiltration into the glomeruli, and they are typically immune complex mediated reactions. Inciting agent antigen is usually a exogenous antigen, which is here probably streptococcal variety of infection, and sometimes it may be endogenous, as in the case of secondary glomerulonephritis seen in the case of SLE or systemic lupus erythematosus. Acute proliferative glomerulonephritis usually seen in children around 6 to 10 years of age, and it is rarely seen in adults. Common agent is streptococcus, and that too a streptococcus which has got an M protein in their cell wall, which we will call it as nephritogenic strains of streptococci, which fall under the category of Griffith types 12, 4 and 1. Other antigens may be exotoxin B or nephritis associated streptococcal plasmin receptor NAP1 or zymogen precursor. Mechanism is they may get implanted, or it may be due to circulating antigen antibody complexes, or it may be altered basement membrane of the glomerulus. So, if you look at the morphology of glomerulonephritis, which is of acute proliferative, the kidney is enlarged and it is congested, and surface may show some hemorrhages. Microscopically, you will see the diffuse and global involvement of the kidney. So, diffuse refers to the entire kidney involvement, and focal refers to the any portion, only some portions of the kidney is involved, and global refers to the glomerulus, whether it is the entire glomerulus is involved, you will call it as global, only a portion of the glomerulus is involved, you will call it as segmental glomerulonephritis. Here in post-streptococcal glomerulonephritis, it is diffuse and global. So, the glomeruli are enlarged hypercellular because of infiltration by leukocytes and macrophages and proliferation of endothelial and mesangial cells. The obliteration, because of the endothelial proliferation, the capillaries will be obliterated, there is interstitial edema, and tubules importantly show red cell cas. So, if you do immunofluorescence, you may demonstrate IgG, IgM in the basement membrane and C3 in the mesangium. Electron microscopy reveals dense humps in the epithelial region, and there may be some mesangial deposits. So, this is the microscopic image of glomerulus involved in proliferative glomerulonephritis. The left image normal kidney stained with PAS, and the right one shows numerous nuclei. Compare the number of nuclei in these two glomeruli. So, numerous nuclei indicating proliferation of endothelial cells, indicating proliferation of macrophages, and also infiltration by neutrophils. And look at the lumen of the capillaries, this is obliterated in this image. And electron microscopy, you will see the subendothelial humpy deposits which are homogeneous and gray. and immunofluorescence showing the bumpy deposits or granular deposits in the glomerulus. Clinical features, usually it is abrupt onset. There will be a history of sore throat 1 to 2 weeks prior to this renal manifestations, and the patient may have fever, oliguria and smoky urine. The azotemia is another biochemical alteration, and invariably they will have hypertension and low urinary output. Their C3 levels will be low and ASLO titers are elevated. Most of the children will recover completely by conservative treatment, and less than 1% may develop rapidly progressive glomerulonephritis. So, if it is occurring in epidemics, it is associated with good prognosis, and sporadic cases the recovery is less. So, to remember the changes in acute proliferative glomerulonephritis, the 3S is a clue. One is type 3 hypersensitivity, because you will see the antigen antibody complexes playing an important role in initiating this glomerulonephritis, and low C3 levels 3 weeks after infection or sore throat, and 3 bumps and 3 lumps, that is for rhyming clue to remember the features of acute proliferative glomerulonephritis. Other features, as I told already, high ASLO titers. So, earlier this glomerulonephritis was known as Streptococcal glomerulonephritis. Now, because of the other agents that are identified to induce similar changes, it is now known as proliferative glomerulonephritis. The other agents that can cause proliferative glomerulonephritis include Staphylococcus, Pneumococcus, hepatitis B and C virus, other viruses like mumps, HIV, varicella and malaria toxoplasmosis also can induce proliferative glomerulonephritis. Coming to the rapidly progressive glomerulonephritis, which is otherwise known as glomerulonephritis, Crescentic glomerulonephritis. This is known as rapidly progressive because the progress is rapid, and if it is not treated, death occurs in weeks to 3 months. Most common, it is also called as crescentic glomerulonephritis because the presence of crescent that can be appreciated under microscopy. Glomerular injury is immunologically mediated. Based on the immunological findings, it is divided into 3 types. One is the type 1, which has got anti-glomerular basement membrane antibody. Type 2 is associated with immune complex mediated injury, and type 3 is pauci-immune. Now it is considered as one type of vasculitis. So, in the case of antibody to glomerular basement membrane, linear deposits of IgG C3 is seen in the glomerular basement membrane, and because of this the antibodies developed against the glomerular basement membrane has got cross reactivity with the pulmonary alveolar basement membrane. The patient may also have sometimes pulmonary hemorrhages. So, this is known as good posture syndrome. It is most commonly seen in those workers who are dealing with paints and dyes and various solvents, and those who have HLA-DRB1. Plasmapheresis may help in these cases. Immune complex induced glandular deposits are seen in immunofluorescence microscopy. In addition to crescents, there is cellular proliferation in the glomerular tufts. Plasmapheresis in this case is not helpful. The underlying disease must be treated. The pathology may be due to henoch-Schönlein purpura or SLE. Pauci-immune, there is no anti-glomerular basement membrane antibodies or immune complexes, and these fellows may have circulating anti-neutrophilic cytoplasmic antibody, which is known as ANCA positive. And recent concept is it is a variety of vasculitis, and the example of polyangiitis, which is limited to glomeruli. So, morphology, the kidney is enlarged, pale, petechial hemorrhages on the cortical surfaces. You will call them as flea-bitten kidney, and microscopically crescent formation is the feature of this glomerulonephritis. And these crescents are nothing but proliferation of parietal cells, monocytes, macrophages, fibrin and neutrophils in the parietal area of the Bowman space. And this crescent formation will result in obliteration of Bowman space. That is the reason why the acute kidney failure is a typical feature in RPGN. Immunofluorescence, you will see granular immune deposits, and good posture syndrome may show linear basement membrane, IgG and complement deposits. This is the gross appearance of kidney involved in rapidly progressive glomerulonephritis, and we will call this as flea-bitten kidney because of punctate hemorrhages that are seen on the surface as if it is bitten by the kidney, bitten by the flea. And other causes for flea-bitten kidney include malignant nephrosclerosis and bacterial endocarditis. So these are the appearances of glomeruli in RPGN, wherein typically crescents are formed in the Bowman space, obliterating the Bowman space completely. So investigations that you can do is anti-glomerular basement membrane antibodies, ANCA demonstration, and anti-nuclear antibody may be of help. Treatment is plasmapheresis and cytotoxic therapy and steroids. Renal involvement may progress over a matter of weeks, resulting in oliguria. To summarize, glomerulonephritis is inflammation of glomeruli. Inflammatory cells, antibody, complement, cytokines participate in the injury. Endothelial injury presents mainly in the form of nephritic syndrome, wherein hematuria, RBC-Cas, hypertension are the features. And podocyte injury results in nephrotic syndrome mainly, wherein heavy proteinuria is the feature. Mechanisms: anti-basement membrane antibodies, immune complex deposition, cell-mediated immunity or complement abnormalities. And diagnosis is by renal biopsy and immunofluorescence studies, and also complemented by electron microscopy. Urine analysis, the main finding is RBC-Cas and varying proteinuria. Good history may identify the etiology wherein there is a possibility for complete cure. And RPGN, you should know, is rapidly fatal, and aggressive approach is essential. Thank you.